Welcome back to Decode Healthcare with Harshal. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're embarking on a really fascinating high-stakes journey. We are going to decode the exact life cycle of how a doctor's bedside note physically transforms into hospital reimbursement. It's quite the ride, so let's get into it. I want to start by asking you something that might actually surprise you. How does a single, seemingly minor clinical detail alter an entire hospital payment? Think of it like the butterfly effect of medical coding. In the incredibly complex world of healthcare revenue, literally one missing word, just a tiny lack of specificity in a physician's note, can completely change a claim's financial outcome. In some cases, it can literally cut the reimbursement a hospital is legally owed right in half, despite the resources they actually used. Crazy, right? So here's our visual roadmap for today's explainer. We're mapping the chronological pipeline from clinical reality to financial outcome. We will hit 1. The foundation, 2. The translation, 3. The multipliers, 4. The guardrails, 5. The intervention, and finally, 6. The final check.
Let's kick things off with Section 1, the foundation, building the claim.
The entire foundation of hospital reimbursement in the U.S. rests on just 3 letters, DRG. A diagnosis-related group is essentially a statistical system that groups inpatient stays with similar clinical characteristics and expected resource consumption into one single payment group. The absolute most important takeaway here is this: the DRG is the single most important factor that determines a hospital's fixed prospective payment for an admission. It is the ultimate destination of every clinical claim. To picture how this works, think of the modern Medicare Severity DRG system, or MSDRG, like a giant funnel. It takes thousands upon thousands of possible diagnosis and procedure combinations and funnels them down into roughly 750 distinct payment categories. These are organized into 25 major diagnostic categories, or MDCs, which are basically based on organ systems. From there, the funnel splits cases into either a medical partition or a surgical partition, totally depending on whether a major operating room procedure was performed. Moving right along to Section 2, the translation, symptoms to diagnoses. Now, we have to draw a hard line between two concepts that get confused all the time: the primary reason for admission versus the principal diagnosis. The primary reason might be something like severe chest pain. That is why the patient walked through the door in the first place. But the principal diagnosis, that's the condition established after study to be chiefly responsible for the admission. So after all the tests are run, that chest pain is officially diagnosed as an acute inferior wall myocardial infarction. That acute MI becomes your principal diagnosis, and that is exactly what drives your base DRG assignment. And guys, if you get this translation step wrong, the ripple effect is just massive. The official coding guidelines state it bluntly: if the principal diagnosis is incorrect, the major diagnostic category is wrong, and the entire MSDRG is wrong. If a coder were to just code chest pain instead of the acute MI, both the hospital's reimbursement and the patient's severity profile would be entirely, completely inaccurate. Let's jump into Section 3, the multipliers, severity of illness. Within almost every base DRG, you'll find this triplet structure. It creates 3 severity tiers based entirely on secondary diagnoses. If a patient only has the base condition, they fall into the without CC/MCC tier, which is the lowest payment. If they have a complication or comorbidity, a CC, it bumps them up to the middle tier. But if the documentation captures a major complication or comorbidity, an MCC, that acts as a massive multiplier. It pushes the claim into the highest payment tier by exponentially increasing the relative weight of the DRG. Let's look at how this actually plays out in the real world. Imagine a patient is admitted with vague documentation like pneumonia and diabetes. That yields a lower paying DRG. But what if the clinical reality is that the patient actually has sepsis and their diabetes is accompanied by diabetic ketoacidosis? Well, DKA is an MCC. By documenting those specific terms, you more than double the relative weight of the claim. It's the exact same patient, but a vastly different financial outcome, simply based on the specificity of the terminology used. That brings us to Section 4, the guardrails, present on admission. To protect the system and make sure hospitals aren't being rewarded for preventable errors, we have present on admission, or POA indicators. Every single diagnosis has to be flagged. Y means yes, it was present at the time of admission. N means no, it was not present. It developed during the hospital stay.
U is for insufficient documentation, and W means it's clinically undetermined.
And this process is incredibly hands-on. Inside the DRG grouper tool interface, coders aren't just inputting ICD-10 codes. Right next to every single diagnosis, they literally have to select a Y or an N from a drop-down menu. The software logic relies entirely on these specific inputs to calculate the final payment.
So why is that physical input so critical? Well, under the Deficit Reduction Act policy, CMS will absolutely not increase payment for an MCC if it developed after admission. For instance, if a patient comes in and then develops a severe deep vein thrombosis, or DVT, on day 3, that POA flag gets an N. It's considered a hospital-acquired condition, or HAC. Even though a DVT is normally a major multiplier, the grouper software will actively block it from increasing the DRG payment because it wasn't present on admission.
Next up is Section 5, the intervention, CDI and queries.
This is where the Clinical Documentation Integrity, or CDI team, shines. They perform what we like to call ethical optimization concurrently, while the patient is actually still in the hospital. Their workflow is basically a 4-step rescue mission. First, they identify ambiguous or missing documentation. Second, they generate a formal, compliant query to the physician. Third, the clinician clarifies the exact diagnosis in the chart. And finally, the medical coder updates the final code.
Think about the real-world triggers to cause a CDI specialist to intervene. If a doctor writes down a vague term like heart failure, the CDI specialist is going to query them and ask, "Doctor, is this acute, chronic, or acute on chronic systolic heart failure?" Or, let's say a chart lists both sepsis and respiratory failure but doesn't link them together. The CDI specialist has to ask the physician to explicitly document if one caused the other. Closing these exact gaps is what prevents massive revenue loss before a claim ever drops. And finally, Section 6. The final check, clean claims.
Let's look at how all our previous components finally synthesize inside the MS-DRG grouper logic engine. Step 1. The engine identifies the principal diagnosis to lock in the base DRG family. Step 2. It checks the secondary diagnoses and those POA flags to assess for the CC or MCC multipliers. Step 3. It scans for major procedures that might shift the patient into a surgical DRG. Step 4. It adjusts for things like age, sex, and discharge disposition. And Step 5, it assigns the final MS-DRG and relative weight. Boom.
But wait, before that claim actually goes to the payer, it faces one last line of digital scrutiny at the clearinghouse. These systems run syntax validations and check for medically unlikely edits, or MUEs. For example, if a claim accidentally bills for 2 appendectomies on the exact same day, the MUE logic catches it immediately and flags it for correction before submission. It is the ultimate safety net.
To synthesize everything we've talked about today, here are the absolute best practices for codability. 1. Be highly specific. Never just say stroke if it's an acute ischemic stroke. 2. Clearly link cause and effect in your notes. 3. Always document exact laterality, left, right, or bilateral, because missing that can easily trigger a claim denial. 4. Keep the daily problem list updated with only active, relevant conditions. And 5. Always clearly distinguish if a condition was present on admission or acquired in the hospital.
I'm going to leave you with a final provocative thought to chew on today. Is your documentation telling the true clinical story? Or are you inadvertently leaving vital revenue on the table? The power of the pen, or, the keyboard, is truly immense in the MS-DRG system. Make every single word count. And that wraps up our explainer for today. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep optimizing, and I will see you in the next one.